how do you assess them, and what do you do usually? What is the rationale?
Well, I mean, the same thing. Look, if somebody's got so I know we're not really supposed to use a pathoanatomical model anymore. So the way I try and explain it to a patient or to other therapists is, because I love Mackenzie's conceptual model. Mackenzie openly said, I don't know if it's a disc, but it seems like a reasonable explanation until there's a better one. And obviously, we don't know that everything comes from the disc. You can have a disturbance in a facet joint. You could have a disturbance in many kinds of tissue in the spine. There are all sorts of bits down there. So what I try and do is just use Mackenzie's conceptual model, except this time instead of saying disc, I say, hey, you've got a balloon. Okay, the balloon is sealed. It's full of toothpaste. But Nick Bogdup said that the consistency of the nucleus of the disc is toothpaste-like. So I feel comfortable saying you've got a balloon and it's full of toothpaste. I squeeze the front of the balloon, the toothpaste moves to the back. I squeeze the back of the balloon, the toothpaste moves to the front. I squeeze the front right side, it goes to the back left. I squeeze the front left side, it goes to the back right. And then I look at a patient, I say, look at you. And honestly, I always take pictures of the patients with their permission, often using their own camera, so they can see the shift. Okay, so it's blatant. Then I say to them, okay, so in your case, the toothpaste is accumulated if they're a right shift, then the toothpaste is accumulated on the back left-hand side. So what we've got to do is move that toothpaste from the left-hand side over to the middle and even slightly off to the right with one movement. And then the second movement simply drives it forwards. I mean, Mariana, if I said to you, you've got a posterior derangement and extension responder, is there any problem, any question in your mind what you're going to do with that patient? So it's exactly the same for a relevant lateral. You've got somebody with a big lateral shift. Is there any question in your mind what you're going to do with that patient? Instead of going back to front, you're going side to side and then back to front. That's all there is to it. It's that simple. The big pointers I would give people when they're looking at relevant lateral shifts is this. A lot of times we try and push people. I remember when I went on the courses, I mean, they told me that people would have autonomic reactions. They'd feel light, they'd get cold, they'd get dizzy, they'd get nauseous. And one of the things I started doing, rather than pushing, I just had the patient go exceedingly gently. I just want you to bring your hips over to, just start to move, whether we do it side glide, whether we do it in standing, freestyle against the wall, whatever the correct load for that particular patient is. I'm just saying, take your hips just to the edge of symptoms, okay? And if they already have symptoms, just to where it feels tight, move your hips across, and it may just be a fraction, and they'll say to you, well, I'm not moving very much. And you say, that's fine. Just move to where you can move. Or what you'll notice is, and you'll see it with the patient, is that just like with retraction or the extension, the point of which they start to stop will occur further and further and further into range. And you're not having this severe pain. You're not having the patient feeling sick. You're not having them get lightheaded. Now, if it's truly a very stiff derangement and what we would call the hard shift, one of the things I've found really useful, rather than jumping into the shift correction, and it may be a little bit of a controversial thing to say, is but I start to address. I did a presentation on this in 2019 for faculty and diplomats. What I've started to use is thoracic spine as a medium of reducing the shift. And what I mean by that is, so, if somebody cannot side glide, one of the things I'll do is I'll actually have them do seated thoracic rotation. I mean, if you think about it, take a step back. Have you ever had a situation where you've got a patient in the cervical spine who has a big relevant lateral component, and it's clearly lower cervical spine, but they're unable to tolerate lateral flexion? It's that big a derangement. What do you do? What do you normally do with that patient if it was yours?
Take out gravity, lie them down.
You could lay down, or what's another thing you can do?
Work thoracic, I guess?
No, well, you can. Or the other one you can do is you can start with cervical rotation. Okay? Because it's too big to go laterally, so you can start gently. I know a lot of the faculty do it because I've spoken to them. You can start gently retracting and rotating, right? And as you do that in nuclear rotation, well, now you start to be able to side flex, okay? And so I might be saying to that patient, okay, the first session in the cervical spine may just be clear rotation. When you come back tomorrow, we'll start working on lateral flexion. Well, guess what? In the lumbar spine, on a shift you can't reduce because it's so stiff, start some thoracic rotation really gently. Start to move it just a little bit. All of a sudden, the side glide starts to return. Using that, I mean, honestly, using that, I would say I haven't done a manual. I'm not saying they're not useful and they're not important to know. They are. But I have not needed to do a manual shift correction in 3 years.
Oh, that's so interesting. I never thought about that.
And it's less stressful on the therapist. It's less stressful. It's certainly less stressful on the patient. Now, is that going to mean, tomorrow morning I'll probably see 3 patients now that I'll have to manually shift correct? But just from Murphy's Law. But honestly, hand on heart in clinic, and I've got pictures of some humdinger shifts that reduce beautifully with thoracic rotation.